So this is a small video about artificial intelligence for MBBS students. Artificial intelligence was slowly becoming a bigger part of healthcare in the coming future, so upcoming doctors should know about it. The format for this talk is it's going to have a little introduction, some clinical problems. There was a poll in the actual version and a discussion, but we can't do that online in a video, so we'll just go straight to AI strengths and weaknesses. My path to AI was not that straightforward. After my residency at Michigan State University, I came and joined Amrita Hospital in Kochi in 2009 and slowly moved up the ranks. COVID came along, and that really threw everything off. But from there, I became a professor and head of the Department of Physical Medicine Rehabilitation. Now, because COVID was such a thing where we had free time, I got back into podcasting and not making them, but listening to them. And the result of hearing podcasts around COVID, especially Harvard Business Review podcasts, where that AI is coming into healthcare and it's a really big thing, and we should be aware of it. So I started getting interested in this, but I didn't have a programmer, I don't program, and I didn't have the technology to do this for my patients. So the way I got started was a small systematic review. We eventually learned enough about AI that we could start running hackathons, and from there, actual projects. The issue as clinicians and department heads that we face is just, there isn't time. I don't know how to code, and there's too much other stuff happening. If someone wants to create drama, I'd take care of that, along with patient care, along with growth of the department. So it becomes an issue. If I had coding skills, maybe I could do more, but we don't have that. Now, as a student, your path to AI could be something completely different. In that you join MBBS, you're going to clear MBBS soon enough, and once that's over, you have a choice to just start working or work on NEET. You can work or crack NEET again. You could work or study more, but eventually, whatever happens, you'll have to start working. And when you start working, you're going to see all the problems that clinicians face. So at your stage of an MBBS student, you're learning medicine, you'll find out what you like in it, you can begin practice, you can learn the ropes. But from there, there's even things that you could do along the side, like coding, where you can play with different AIs. You can see what you can and can't do and what problems emerge. So when problems emerge at work, you actually have a second set of skills to tackle those problems. Also, what and what not to do when problems persist. So the idea is that you gain a separate set of skills along with your clinical skills such that you can merge these two so you can continuously have solutions ready for problems. That, of course, is very boring, so I'm going to give the rest of the talk to you in this format of 7 MBBS friends. They're all buddies in medical school, and life kind of moves on. So as life moves on, we have different people, like Kavita, who wants to help people, Ansi, who likes to crack a tough case, Santosh, who wants to do something really well, Dindigala, who wants to do something really unique, Makbulia, who likes to make systems run, John, who wants to do something really well, and no drama. And from there, we have Alicia, who likes to help people. But Dindigala is kind of the star of the show, and he wants to do something really unique. Now, these are who they are as people who are doing MBBS. But life goes on and things happen. So Santosh and Kavita, they know each other. They get married. And then Alicia and Makbulia, they have a thing for each other. They're not really married, but they have a thing, and one thing leads to another, and they have a kid. Santosh and Kavita, they also have a kid because they got married. The other three people stay in the singles pool. Now, Makbulia's kid and Makbulia and Alicia's kid is not exactly normal. He has autism. And for him in his stage of life, this is just too much. He doesn't need this extra problem. So he says, yeah, I'm noping out of here. And he gets out of there. He joins the singles, and mom takes care of her baby. Not the best of situations, but life plays out like that sometimes. Now, where did these guys end up? They finished studying, and They all start working. Now, Kavita is a mom. She's also taking care of a family, her husband, and she wants to work, so she stays in MBBS general practitioner. And she goes on to do a MD in physical medicine rehabilitation and a pain fellowship thereafter. Santosh goes and super specializes. His family is together. He has a wife. She supports him, and he becomes a big foot surgeon. There's a lot of money in diabetic feet. Magnolia doesn't really want any more drama, so he kind of goes into hospital administration. No more excessive problems. It's just kind of a stable job, so he thinks. John doesn't really want drama, so he does MD pathology. And Alicia, she has her baby to take care of. Mom and dad help her in the daytime, but she has to make money and take care of her family. So she gets a job in MD anatomy. And it's a stable job. She works in a teaching institute. It's not the best pay, but it's a regular salary that she can work on. And when she comes home from work, she can run her clinic and take care of people in the neighborhood. So they all get to do what they like. Dintigala is kind of the outlier here. He goes and does a Bachelor of Computer Application AI and becomes an AI programmer slash doctor. So let's see how things play out here. Dintigala, the AI programmer, goes on to become a co-founder for a health AI startup, and it's called Acme Health. And there's its logo, which I stole from the internet. And he keeps in touch with his friends through WhatsApp. And they all know what he's doing, but they don't really know what he's doing. And he knows what they're up to. Magbulia becomes an administrator in a hospital network. And all of his friends from medical school, they work under him. He is their boss. They have to answer to him. So he manages a healthcare system where there's primary healthcare centers, there's teaching hospitals, there's everything. And he's kind of in charge of those kinds of things. And the challenge he faces is staff scheduling. So there's bed occupancy, there's rising costs, there's insurance issues, all kinds of different things that he has to keep sorting on. There are lots of number games involved with these things. Keeping all the hospital beds open means you have to have enough nursing to watch those beds. You have to make sure all your beds are full so that you're not wasting money. And then from there, you have to tackle rising costs because the competition down the road might not be playing clean, they might be playing dirty. And then, of course, insurance costs. The hard part for Maqbulia is he has to answer to the board of directors, and they don't see the work he does, they see the numbers he generates. So as long as the hospital's making money, they're okay. But if not, like today, they call him and say, hey, you messed up. And why? The competition down the road, they're cheating, they're really being unethical and stealing patients, and it reflects in his numbers. His numbers are lower than they should be. So he's doing his job every day. There's no problem with what he's doing. It's the other people that are cheating, but he gets frustrated. And when he gets frustrated, he doesn't know what to do, but he talks with his friends. And here's Dindigal, the AI programmer, and he's venting all his woes to his friend, and his friend does what he didn't expect. And Dindigala says, we could use AI to manage your resources and forecast surges. Meaning, with an artificial intelligence into their electronic medical record, they can see where all the resources for the hospital are, how to allocate them best, and then say the state government decides to flood the city. You're going to have an increase in waterborne diseases. You would need more antibiotics. You might need more ICU beds for septic shock. So all those different things come up. And if you can forecast this and you can buy up all the resources before someone else so that your hospital has everything ready. This is the business side of healthcare, and it's kind of dirty, but this is where our administrators work. So Maqbulia this sounds like something really good to him. And he goes back to the board of directors and says, look, please, please just give it to me. I can make more money. I can do my job better if I have this. And the board is like, that's a great idea. Go for it. They like money. The limitations with AI, though, are going to be you need clean data and real-time data. So if you don't have data that's fresh and highly relevant, you may be predicting the wrong kind of things, or your data might mislead you to making wrong decisions. So for hospital administrators, what they do is make sure the hospital keeps making revenue. And that means documentation because nowadays insurance companies are taking over healthcare. People don't pay out of pocket anymore. Insurance companies can't keep people in the hospital, so they look at the notes the clinicians make to ensure that something actually happened, so they're paying money for real services. But as clinicians, if you're like me and you have office every day, once you're done serving one person, the next person's trying to jump in. You could be taking care of one person, someone else just walks right in because they think they're all that. So you're trying to deal with so many different things at one time, and making notes is not a big priority, but of course it is. So burden of documentation is where you can just speak and have it turned into a text and you proofread that and make sure it isn't really wrong. Now, it sounds great, but I've been using a text-to-speech AI for about a year and it's pretty horrible. I end up spending more time correcting it than it learning from me. Every time I turn it off, it goes and starts from fresh and makes the same mistakes again. But these things are options and they will improve with time. Appointment scheduling inefficiencies. So many times we don't know who's going to come for an appointment or not, but with an AI you can send push messages and notifications to their phone to see are they really coming or not. Where are they? You know? And you can optimize your bookings that way. So you're not having a doctor or a clinician sit in the clinic waiting for someone to come. They could be freed up for a procedure. If they have an emergency, they can go and come back. They know how much time is being blocked up for work during work hours. Insurances, again, if there's automated documentation, you can process a lot of bills faster so things aren't happening that are a problem. And you can automation reduces insurance fraud and increases speed, so the hospital gets its money from the insurance company faster. It may not be the right amount. Insurance companies never pay properly, but that's a different issue. Resource allocation. So there's good models that require real-time data and buy-in from the staff, meaning you really have to know who your staff are. Meaning, if it's Good Friday and Easter Sunday, and your particular parts of your staff might want off, some may not mind working. Some where you think they wouldn't mind working might actually want to go somewhere. So as long as your staff tells you the truth when they answer these questions, you can have better information to make plans and how we schedule resources. So that's Makbulia, but let's look at some clinicians here. Kavita is a general practitioner. She works in a busy urban clinic, 2 to 300 patients in a day. Typical for an Indian clinic. Too many patients, too little time. And this is her. Every single day, patients pouring out of every opening. And then she knows how to keep up with things and make things go, but then she gets a phone call. And the phone call is her boss, and he says, more. More what? Her boss wants her to order more and more tests. And by ordering more and more tests, he's going to be able to show the board that he's making money and the hospital is doing well and it's worth keeping Kavita as an employee. But that's not really ethical practice. You can't just tell a doctor, go order more tests. That's corporate culture. It's very unhealthy. And he knows, and Kavita is his friend, and he can't say things that are wrong. She'll tell him off if he's wrong. So what he says is, look, we're in risk of shutting you down because you're not generating enough revenue. And she's, okay, what do I do? And he says, look, I have a solution. You remember Dindigala from her batch who's doing all this crazy AI stuff, and Dindigala pops up and says, hey, look, you know, we can use AI to make clinical decision support for triage and prescribing. Now, what does that really mean? It means that the AI will get a bunch of data on this person and some real-time data to see how they're doing, and it's going to start putting into a list who Kavita should be seeing first, who she should spend more time with, who just came for a drug refill. meaning it's a lot easier for her to get things prioritized. The catch with this is AI runs on data, it doesn't see people. So you need to have some testing done, meaning Makbulia gets what he wants. The patients are spending more money at the hospital and the clinics, the lab is generating more revenue, and Kavita has more information to work with. Probably not more than her own eyes and clinical skills will tell her, but it's generating revenue and it's validating her existence in this healthcare system. So the question we have to ask ourselves is, when is AI a crutch versus a tool for better care? And as long as a clinician is aware of where AI can be right and wrong, then it's going to be more of a tool for better care because it can say, AI, you're wrong, this is not the time to do that, versus a crutch where you have a generation coming up with AI that don't know what to do except ask the AI what to do until they make a mistake and get in trouble. So there's a lot of diagnostic delays that can happen in a primary healthcare center. People with emergencies can walk in and die. It doesn't happen too often, but it can happen. And there can be errors. So if you have an AI that's assisting with differential diagnosis and clinical decision support, then the clinician's work is a lot easier. Again, clinicians have to make lots of notes to show what they're doing or even just remember what they've done before. So again, if you have natural language processing tools, they can automate notes. And again, it sounds better than it is, but for where it is right now, it's not bad. If you look at Apple's iPhone software for messaging, it's quite good. If you look at the other systems, it may not be that great, but they can improve. Nancy is a physiatrist, and she works in a tertiary level hospital, and she does brain and pain rehab. So people come in with a stroke and general medicine, neuro, stroke medicine, they all take care of this person. They bust the clots, they suck them out, but the person has residual brain injury, and because of that, they can't walk and talk and do their daily activities. So she gets involved, and one day she gets a dreaded phone call. And who is it? It's boss. And boss says, look, you're wasting money. And she's a good physiatrist. She does her job. She runs a very successful rehab practice. So what's administration's problem? Well, the thing is, if you have a lot of rehab patients, they're probably going to be a mix of people who will go home soon or some who will take time to go home. The ones who take time to go home could block a bed for a month versus your average hospital stay patient who might be 3 to 5 days. You're now blocking out almost 6 times that with one patient who's not going to do a bunch of testing, not do a bunch of fancy drugs, so they won't be making a lot of money for the hospital. It is good patient care to provide care for them and make them walk and go home, but it is also a problem for the hospital. So administrators usually say, look, don't waste your time with these guys. They're not going to ever walk and properly forget about them. And we know high quality rehabilitation in an institution can make a big difference compared to a local therapy center. But again, administration's looking at money. So she's wasting money. And of course, she knows she's doing her work. He knows she's doing her work. But what do you say? So he says, look, what if we bring in our AI guy? You know him from school, and AI guy says, look, we can use artificial intelligence to read all the images of these stroke patients and then tell you who needs to stay for a week, a month, or who might go in a body bag. And this sounds pretty good because many times on daily rounds, Nancy has to answer the family. When will this person walk? Will he walk? Will he get his speech back? When will he get his speech back? Now, there's actually pretty good publications using existing scales that inform this. But again, an AI that's going to train thousands of models any day better than a clinician trying to guess the future. There's some objectivity with this AI. So Nancy said, okay, that sounds pretty good. I can answer questions on a day-to-day basis, and if things go off, it's not a big problem. I know how to answer the families then too. Now, the issue we have here is what we see as AI in India is only emerging, and it's been going in the West for about 20 years. So what happens is, when we get into AI initially, we might be using some Western countries' model, and white people are not the same as Indian people. Their biochemical anthropomorphic parameters are very different from ours. An Indian with a BMI of 25 will be overweight, but a white person at BMI 25 might just be ideal weight. And that's just because of the way our bodies are composed and things like that. So when you get into AI and you start using Western models, it won't be optimal for an Indian population, but also you're feeding that Western company Indian data. And now what can happen is if enough hospitals buy in, you're now selling your Indian data to them, and you're paying them money for them to come back and sell you the Indian data set later on. Meaning, they gain all this Indian AI information, they run it through their model until they make their model perfect, and you'll always be paying them money for a data set that you actually fed them. This is a real problem. So large language models for disease trajectory and prognostication are a good thing. You can start answering families in a more straightforward fashion with objective evidence. You can also monitor chronic diseases, seeing how people are doing at home and see when they're getting worse and ask them to come in to fix things before they become a problem. Santosh is a foot surgeon, and if you haven't been in a hospital before, surgeons are very, very powerful people. Whatever small procedures they do make big, big money. And it takes a lot of skill to pull these things off. Now, Santosh and Ansi chat, and he hears about this large language model that predicts who's going to get bad. Now, Santosh has a problem, and the problem is late presentation of ulcers. All of his patients that come in have these ulcers, and it's really, really late. I wanted to see how many of you will actually pick up the problem with this photograph. But also, Santosh is an ethical surgeon. See, an unethical surgeon can allow things to get so bad that they have to do a surgery and make money off a person. But Santosh isn't like that. He really wants to prevent those ulcers from getting worse, and he knows now that AI can actually help with this. Surgeons are powerful. He gets a bit aggressive with guess who? Administration. And administration says, yeah, we can help you with that. Here's our AI guy. You remember him from school? And AI guy says, look, Santosh, you can just keep doing your surgeries, sitting in your clinic, talking to your patients. We'll train an AI to go through the medical records electronically and find out who's going to be a high-risk patient. So that sounds pretty good. Santosh can do what he likes, and the system will suggest to him who should be called back for a review. That's a pretty good system. The thing is, outcomes. So if a bad outcome happens, who's gonna suffer for it? And what that means is now you have an AI telling Santosh who should be called in. If Santosh says, hey, AI, you told me this person should come in, and I think that's wrong, and then the person goes and dies, it means the AI made the right suggestion, but the surgeon made the wrong decision. So what the outcome is the surgeon is wrong, and the surgeon will get penalized for it. The other side is if the AI is wrong, so AI tells Santosh, bring this patient in. Santosh says, I know this guy, I saw him yesterday, he's perfectly fine, he'll live for another month or so or longer. When the AI is wrong, well then what people do is say, oh, the AI model was wrong, just send it back to the lab and work on it some more. Meaning every time the AI is great, people are going to say, AI has saved humanity from humans and the surgeon was wrong. But when it's wrong, we'll just send it back, work on it again, right? So this is a bit of an issue because we are the ones who are liable in this healthcare system, and that's why we have to have the final say. So Santosh gets his thing, and now he can personalize all of his treatment. He has to make better notes, he has to order more lab values and that kind of stuff. But he gives it high quality information and he gets better information. He can have an assistant guiding him in real time when he gets to work who he should be calling for review. Santosh now has a gallery of foot pictures of all of his patients, and he can see how their feet are doing on a weekly basis. John never really wanted drama. He just likes to do things well. But he's overwhelmed by the histopathology lab. And there's too many slides and too few pathologists. It takes a week to get the entire section ready before it can be read. And what's worse is one day a patient has a big temper tantrum. It's been 3 days from their surgery and they're angry that they haven't got their final report. And patients don't understand that it takes a week to get these things ready. They just know they have pent-up emotions and anxiety. So this patient in particular goes on the social media and has a temper tantrum. This is an imaginary picture. Please don't look at the content because it's not real or relevant to this talk. But this person is a social media tirade. And guess who gets to hear about it? Administration. And administration thinks, my God, what can man do against such reckless hate? And he only has one option. He gets on a call and tells John, mush, make it faster, come on. And John's like, reality is it takes a week to make these slides get ready and read them. You can't do it any faster. And McBoy says, I know, but people are complaining. So Makbulia gets Dindigala involved, and Dindigala says, yeah, we got a solution for that. And look at this. We can use AI to start flagging suspect errors in slides. So now the AI is going to read the slide before the pathologist, and pathologist will just confirm what the AI says. So John gets this, and now he has too many pathologists in his lab. John gets on an airplane, he goes to Aruba, he's sitting at the beach, having fun with the locals, and every few hours he pops into his computer and does the final verifications on what the AI has told him about the slides. His technicians run the lab, they do all his sections, they mount images for him, and he verifies. Now, is this really okay? It's hard to say, but the hospital is making its money. People can complain. They can market and say it's the AI's fault. We're waiting for the AI to read it. So they can't target John anymore, and John is a free man. The question really is what happens to the next generation of pathologists? If John does this, what happens to his students and future pathologists? So AI can help in pattern recognition. It can reduce workflow bottlenecks. It can reduce human error and fatigue and detect rare abnormalities. And at times, AI can outperform generalists who aren't really that specialized in things. Alicia is our last person. She's a mother. Her child is autistic. And through the day, her parents take care of this kid. And she goes to work and makes money for her family. And when she comes back, she has her private clinic out of home, and things are pretty good. The thing is, her kid has problems and can start acting out, and as he gets older and older, it's harder for the grandparents who are getting older to take care of the child. So she occasionally has emergencies. Now, teaching preclinical students is kind of a thing because they're kind of a young group of people who don't really see the bigger picture. So it's low engagement, it's passive learning, it's just repeating the same lessons over and over again, and then there's an emergency, so she has to go home, and what happens? The kids start misbehaving. They start having fun, they talk loud, they make animal sounds at each other, they get into their gangs and argue, all the usual stuff that students will do, right? But now this disorder gets to the word of administration, and administration says, look, no more leave, or else you can't just get up and walk out of the hospital and take care of your kid. That's not okay. You can't do that. And she's an employee here. She's the head of a department. She's taking care of all these students. Students in private sector hospitals are a good source of revenue. So he can't afford to lose Alicia, but he can't have her walking out and having these students misbehave. So it's kind of a tricky situation. And what Makbulia says is, hey, look, here's our guy Dindigala, and Dindigala says, We can use custom virtual reality for anatomy with real-time feedback. And means the VR is going to start teaching the students in real time. And these kids, they're glued to screens anyway. This is nothing more than an attachment of what they're already doing, and they can learn this way. So Alicia, she likes that. It makes sense. But the discussion we think about really is a student learns to use an AI tutor to master neuroanatomy through simulated dissection. Does it replace cadaver labs? As a physician, I would still say that my time with the anatomy lab was very, very useful. I inject stellate ganglion, celiac ganglion, I inject all sorts of structures. If I had not spent time with the actual human body in my hands, I wouldn't be as confident. Now, the other thing is, as students, you don't know if they're going to become surgeons or physicians. So a surgeon really needs this. A physician is stronger for having it. There's many Western countries where students don't get exposure to actual cadavers. They get to look at a theal embalmed limb for about 5 minutes and they can't touch it. So it's very useful to have a cadaver lab. But AI can now turn passive learning methods into something that's very personalized for students. It can actually answer questions for them. It can do it at their own convenience. I did have colleagues in internal medicine when I was a resident there who trained in the Gulf and Caribbean countries. And they'd spend their entire day at the beach with the local girls, but in between the fun, they'll put on videos and watch their lessons. And they do their anatomy kind of well, and it was kind of at their convenience. So you don't need a teacher physically present all the time, but students can learn when they're ready. Now, you can also predict drug interactions, and you can give students simulators to work with. You can simulate biological processes and add problems and see what happens, and that's how we can learn without hurting people. All of us are going to keep getting older. We're not getting younger. AI is growing along with us in healthcare as we speak. AI again has made problems with a photograph. I don't know if you can detect it or not. But it's important that we learn how these things interplay with us so that we can be in a position of command and control so we can provide better care for patients. The thing people ask me is, what in healthcare is actually safe from AI? You may have not seen this guy before, but he's strapped into a robotic gait trainer, and this is making him walk. This has an AI on board that assesses how the person is being made to walk, and it can normalize their gait pattern. This is a patient who had a surgery where his deltoid was flipped into his trapezius was flipped into his deltoid. And this is a brace that we custom made for him to slowly lower the arm down into position. This is a bionic hand that we market through our department for upper extremity amputees and two of our students. And this hand has an AI on board. Here's a virtual reality hand trainer for hand functions. And you can see people can now engage both their hands in a mock-up situation to do particular functional tasks. Most MBBS students will never hear about physiatry. Only about 5% of students will go to schools where a PMR department exists. Many places will have physical therapists around. Those are the paramedical technicians for our department, but they won't see physiatrists. So before I talk about my own work, then we have to understand what physiatry is. And it's essentially rehabilitation, meaning the best healthcare is prevention, where you make legislation and educational materials to prevent people from getting sick. There's no money or power in that. 95% of doctors will end up in treatment, the treatment section, where they're going to be treating people and treating conditions and looking at disease and treating that. There's a lot of money, power, glory, and splendor in those kinds of things. It's better to prevent problems, but yeah, all the power is in treating people. Once you've treated conditions and a person has not gone back to their daily life or doing their daily activities, they need rehabilitation. And that is medically supervised rehabilitation considering the person, their comorbidities, and what they can actually achieve. That's what we do on a daily basis in physiatry. And of course, when there's nothing left and the person isn't going to live much longer, but they need to go in dignity, then there's pain and palliative as a department. So my work with AI, now that you know what AI is, I can expand a little bit more. I started with podcasts and moved along the way, but one of the first things was a systematic review. I didn't know how to write one, but I had people help me and we got this done. And it tells us how you can use AI and machine learning to predict pain. My colleagues in the engineering college called me up one day and said, Rebbe, can you help us with this? And what they did is they had a data set of people who had epilepsy, had an EEG at the time of their seizure, and an ECG. And the ECG will show you if they're having a seizure or not 30 minutes before it happens. So this is breakthrough research the world has never seen. The actual hospital that made this data set couldn't do it, but we got it done. The next thing is seizure information enrichment. So with the same data set that we were working with from Temple University, we went forward and now started breaking these things down by their presentation. And you can say this kind of seizure is coming, that kind of seizure is coming based on all of this. We run hackathons. This is our engineering college and artificial intelligence school coming together with clinicians to try to solve problems that stroke survivors face. We had another hackathon last year, and that was for making customized diet plans for people to target their wellness rather than their disease. This is a big problem clinicians face. They don't understand nutrition or how to make people eat healthy. Many eat trash and somehow survive. The last is after doing rehab now for 16, 17 years, you get tired of it and you kind of want to prevent disease. So we're making chatbots to promote wellness. That's all.